Hello everyone, I'm Dr. Sakshi and today we'll be discussing about jaundice, approach to a patient of jaundice. So when a patient comes with jaundice, we look at the LFT and we see the bilirubin level, the enzymes level and the ALP and GGT level. First of all, if we see that the patient has only isolated hyperbilirubinemia, so we have to see whether it is direct hyperbilirubinemia or indirect hyperbilirubinemia. If it is direct hyperbilirubinemia, that means the direct bilirubin is more than 15%. So the causes of direct hyperbilirubinemia are the genetic causes, that is the Dubin-Johnson syndrome and the Rotter syndrome. Then comes the indirect hyperbilirubinemia. Indirect hyperbilirubinemia means that the direct bilirubin would be less than 15%. So indirect hyperbilirubinemia, the causes are drugs like rifampicin and probenecid. Then there can be hemolysis, or there can be certain genetic causes like Gilbert syndrome and Crigler-Najjar syndrome type 1 and type 2. Also, there is ineffective erythropoiesis, that is also an important cause of indirect hyperbilirubinemia. Then we see the enzymes. If the enzymes are elevated more, that means there is hepatocellular pattern. In that case, first of all, we have to rule out the virus causes or the viral hepatitis, for which we have to do the common viral viruses, that is hepatitis A, B, C, and then we can also do Epstein-Barr virus and cytomegalovirus, which are less common causes. Then, if the patient is less than 40 years of age, we have to do the serum ceruloplasmin level to rule out the cause, to rule out Wilson's disease. Then, also we have to do the ANA level, then SMA level, serum protein electrophoresis to rule out the autoimmune causes. Then, if we see that the ALP is more elevated than the enzymes, in that case we have to rule out the cholestatic pattern, the cholestatic cause, for which we have to do the imaging to rule out the duct dilatation. If the intrahepatic ducts are dilated, that means there is some extrahepatic obstruction, for which we have to do CT, MRCP or ERCP. Now, if the ducts are not dilated, then we have to rule out the intrahepatic cholestatic causes, which could be autoimmune causes, for which we have to do AMI. Then there can be some drugs causing this stasis, or viruses that can also causes the stasis. But if all of these are negative, then we can do the MRCP to rule out the cholestatic cause.